Patients present as newborns with clinical evidence of cyanosis with or without respiratory symptoms such as rapid breathing. Central, perioral, and peripheral cyanosis is noted, but intensity varies. Lungs are clear with normal or elevated respirations. A cardiac murmur is generally present in most conditions. Peripheral pulses and capillary refill are usually normal chest radiography. Lung fields appear oligemic, hypoperfused, dark, without infiltrate or effusion. Overall heart size may be normal or slightly increased. A right aortic arch presents in approximate 25% of patients with tetralogy of Fallot (TOF). A classic boot-shaped configuration described for TOF may not be seen well. In neonates if thymic shadow is present. Electrocardiography. If normal for a newborn, rightward axis 90 degree. 150 degree with right ventricular. RV dominance. Think of TOF abstains malformation of the tricuspid valve or single ventricle with PS. If axis is 0 to 80 degrees with decreased RV force, think of critical pulmonary valve. Stenosis, pulmonary valve atresia with intact ventricular septum. If axis is leftward, less than 0 degrees, with LV dominance, think of tricuspid valve atresia. Pulse oximetry/arterial blood gas sampling. A pre- and postductal oxygen saturation should be checked in room air. In the absence of a primary lung problem, a pulse oximeter reading at rest less than or equal to 93% is abnormal. Visible cyanosis, however, is not usually obvious until the pulse oximeter reads less than or equal to 85 to 87%. Systemic hypoxemia and respiratory symptoms may start at saturations less than 65 to 70%. A hyperoxia test should be performed. The patient is placed in 100% oxygen for 10 minutes followed by pre- and postductal arterial blood gases, not oxygen. Saturations. To assess 1. Acid-base status, 2. Ventilatory status, 3. Responsive PO2. To oxygen in a cyanotic cardiac defect, the PO2 will not change. If a pulmonary process is present, the preductal PO2 will increase 150 to 200 torr. And 4. Comp. Pre- and postductal PO2 to delineate a right to left ductal shunt to the body. Echocardiography is able to accurately define the anatomy and physiology of most cyanotic heart disease, thus guiding treatment. Gradients across the pulmonary outflow tract, pulmonary valve annulus, and right ventricular size. And pressure can be measured. Cardiac catheterization. Used to assess size and continuity of hypoplastic pulmonary arteries, distribution of aortopulmonary collateral vessels, and the coronary arteries in pulmonary. Atresia with intact ventricular septum, which may be RV-dependent hypercyanosis, spells, metabolic acidosis, death, endocarditis, arrhythmias or sudden death, intracardiac right to left shunt, stroke, embolus, brain abscess. Polycythemia according to degree of cyanosis, limited pulmonary blood flow with CHD, TOF with or without pulmonary valve atresia, critical PS, tricuspid valve atresia, pulmonary valve atresia with intact ventricular septum, abstains malformation of the tricuspid valve with pulmonary valve stenosis or atresia, or single ventricle with PS or atresia, limited pulmonary blood flow without
CHD, persiste fœtale circulation.
Cyanosis due to non-cardiac causes. Infiltrates, effusions, pneumothorax, congenital, diaphragmatic hernia, cystic adenomatoid, lung malformations and airway anomalies. NO-specific dietary interventions are necessary. After surgery, patient's activity level is dictated by the presence or absence of arrhythmias, ventricular dysfunction, or residual shunting. Teenagers with palliated single ventricles or repaired complex heart disease may have limited exercise capacity. Pharmacologic treatment. For neonates, if oxygen saturation is low, less than 70%, and does not improve with supplemental oxygen, then the ductus arteriosus must be reopened. Standard dosage prostaglandin E1 PGE as a continuous infusion 0.05 to 0.1/kg/minute. Side effects: PG, apnea, jitteriness, vasodilation, tachycardia, seizures, fever, thrombocytopenia. For transport, the airway must be secure. For postoperative patients, digoxin and diuretics are common in patients with single ventricle after aortopulmonary shunt, and similarly after complete repair of TOF. Standard dosage digoxin maintenance dose 5/kgpo every 12H, IV. Dose is 75% of oral dose. Furosemide ranges 1 to 4 mg/kg/d every 12H. Special points furosemide. Check electrolytes. Hypokalemia is associated with cardiac arrhythmias. Non-pharmacologic treatment. Interventional cardiac catheterization. Indicated for patients with critical pulmonary valve stenosis with adequate sized right ventricular cavity. Balloon dilation of the stenotic valve is highly successful. Palliative shunts. In patients dependent on PGE to maintain pulmonary blood flow, a modified Blalock-Taussig aortopulmonary shunt precedes later surgical intervention. A 3.5 to 4.0 mm imprograft or Gore-Tex shunt is anastomosed between the innominate artery and its corresponding branch pulmonary artery. Non-pharmacologic treatment. Rashkind procedure. Balloon atrial septostomy indicated for patients with DTGA and intact ventricular septum and restrictive foramen ovale. This non-surgical creation of an atrial septal defect, ASD, allows oxygenated blood from the left atrium to cross into the right heart and go to the systemic
Circulation, improving circulation.
surgical treatment. DTGA, without fixed LV outflow tract obstruction, the preferred surgical procedure is an arterial switch operation, ASO. The aorta and PA are switched back to their appropriate ventricle. The coronary arteries are transferred from the anterior native aortic root to the posterior neo-aortic root. Associated ASD, VSD, patent ductus arteriosus are also repaired. A repair is early in life, first 2 weeks of life, when the LV is prepared to pump against a high afterload. Truncus arteriosus. Complete surgical repair, VSD closure, placement of a RVA conduit, is accomplished within the first few months of life. Later repair is associated with pulmonary hypertension and high mortality. TVC. The confluence of pulmonary veins is anastomosed to the posterior aspect of the left atrium, which may need augmentation, and the obligatory ASD is closed. In patients with partial or complete obstruction, surgery is mandated. In the neonatal period, in patients with unobstructed TAPVC, surgical repair occurs within the first few months of life. Treatment aims to achieve acceptable systemic oxygenation prior to definitive surgical
Intervention.
to protect the pulmonary vascular bed from high pressure and or high flow. The ultimate goal is to normalize intracardiac flow patterns when two ventricles are present.